Good afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of HFMA. The topic for today's webinar is Uncompensated Care Reimbursement Strategies. I'd like to welcome today's guest presenter, Chad Krcil, who is a senior manager in CROWE's healthcare advisory practice. He has over 25 years of experience in healthcare finance. He has over 18 years of experience in healthcare financial consulting with a focus on regulatory, revenue cycle, and financial operations services. Chad is an active member of HFMA, both in his local chapter and on the national level. He currently serves as the president of the Colorado HFMA chapter. Chad also presents Medicare reimbursement strategy courses for local chapters as well as on a national level for HFMA. So without further hesitation, I'll hand the call over to today's guest presenter. Chad, please go ahead.
Thank you, Nikki. Appreciate it. Good afternoon to everyone on the phone, and thank you very much for taking the time to join us today for a brief overview of several different uncompensated care reimbursement issues and some strategies around those issues. So welcome to all of you listening, and my hope is that you'll be able to take something over the next hour that we're together here and walk away and have some good ideas for what you're doing at your different facilities. So we'll go and get started here. Since Nikki already introduced me, we'll skip that first one. Really what I like to say that we're doing as we go through these type of webinars and educational sessions is we're trying to, simplify the business of healthcare. So trying to talk about different things that are going on in the world of healthcare reimbursement and make sure that you have strategies around the different areas that are affecting reimbursement as we know it today. So today we're going to talk a little bit about disproportionate share payments and 340B, S-10, and Medicare bad debts. So those are the three things on our agenda that we will cover today. Some of the objectives is really take a look at those areas we just talked about and talk about some of the ways that we can identify things that are affecting reimbursement and may help you going forward in that reimbursement area. We'll take a look at some of the key drivers behind those uncompensated care areas and what can be done by working integrately with revenue cycle and the reimbursement. And we'll take a look at how by being kind of collaborative in that approach, it will hopefully enhance your reimbursement in these different areas. Some takeaways that I've got throughout here are, some recommendations on Medicare bad debt documentations. We'll talk about the charity care log and some of the things that should go into a charity care log. And then, as I mentioned, there'll be a slide that kind of shows different areas that drive reimbursement in the different issues that we're going to talk about today. So we're going to jump in just quickly and talk a quick moment about revenue cycle. One of the things that I really promote is that collaborative effort between the reimbursement and the revenue cycle functions. Everything that goes on in the revenue cycle side of the world affects what goes on the reimbursement side of the world. So if things aren't being done the way they should be being done on the revenue cycle side, or that needs to be done to enhance how we report things on the Medicare cost report to enhance the reimbursement through the Medicare cost report, there's some revenue being left on the table. And that's whether we're talking about the front end, when we're talking about the scheduling, registration, point of service collections, what are we doing on that front end to really identify what each one of our patients that come in the door, what kind of insurance they have. In that middle revenue cycle area, what are we doing to make sure we're capturing everything so we know what went on during the patient stay so that we can bill appropriately and make sure that everything that happened during that encounter has hit the patient bill and that things are being billed correctly. And then on that back end where all the financial management and billing is going on, what are we doing on that back end to make sure that we have billed appropriately, we have worked any denials to make sure that we are getting the reimbursement that we need to be getting, and what is going on really to make sure that we leave nothing on the table, no revenue on the table. So really is a collaborative effort, in my view, of that revenue cycle and the reimbursement area working together so that the revenue cycle understands where things and maybe policies they've got in place might be affecting the reimbursement in a negative way, possibly, that we can fix to make sure that we are getting all the reimbursement through Medicare that we should be getting. So that's just kind of a quick overview of that collaboration that I'm talking about. Quick discussion just about the Medicare cost report, because there were some changes in the 2019 final rule that came out that affects the documentation that has to be supported, has to be sent in with the Medicare cost report. And the final rule is updating some regulations around some different areas within that. The current regulations require providers submit a CMS 339 as a supporting document for an acceptable Medicare cost report. Well, that 339 has kind of went away over the last several years. That information's right in the Medicare cost report on S-2. So that area was something that was addressed this year. Next, currently cost reports for teaching hospitals can be rejected if the hospitals do not submit an IRIS diskette at the time of filing. That word diskette, obviously we don't submit diskettes anymore. So that was another issue that was addressed this year in the final rules. Under the current regulations, providers are only required to maintain sufficient financial records for proper determination of costs. So information that supported your Medicaid days for DISH and charity care charges was something that you did have to maintain, but did not have to be submitted with the cost report in order for it to be accepted. So some of the things that were addressed going forward in the 2019 cost report and the 2019 final rule, so effective for cost reports filed after October 1st, 2018. First of all, in that cost report reimbursement questionnaire, the wording of the CMS 339 had been eliminated, and basically they added wording that just the state providers must submit all supporting work papers for the Medicare cost report. The IRIS data, basically they removed that information, that word around diskettes, they removed that and put in their intern and resident information system data. So that needs to be filed. So it's something that really had always been filed. It was just a matter of correcting the wording within the regulations. And then effective for cost reports again after October 1st of 2018. The Medicare bad debt listing has to be submitted, and it does have to tie to the cost report. If it didn't tie to the cost report, here is that you do have to submit the supporting documentation now with the Medicare cost report on your Medicaid days. That doesn't affect the hospital's ability to still amend the cost report within a 12-month period for Medicaid days that weren't originally reported, such as pending Medicaid days. You still have that opportunity within 12 months to do that. But in order for the cost report to be considered acceptable and not rejected, the information supporting those Medicaid days does have to be submitted with the cost report. So you can see where Medicare bad debt and disproportionate share are two of those issues that need to be paid attention to going forward as far as the documentation that you put in. Then the next one I'm going to hit on here is S-10. So lot of things going on with S-10 and our uncompensated care payments for hospitals. And one of the big things is that a log of your charity care does need to be submitted. And that right now, the information that does need to be submitted on that log is patient detailed information, patient names, dates of service, and that listing must correspond with the amount that's claimed on your worksheet S-10. So, in the past, that log had not been required to be submitted with the cost report. Obviously, through different audits that I'm sure many of you on the phone have experienced, you realize that you do have to have a log, you do have to support that information, it has to be auditable. And one of the things going forward is with the submission of the cost report, you need to make sure that you do submit that charity care log that ties to what you're reporting on the cost report. So those are some of the things that have changed that you need to make sure you're aware of as you file your cost reports after October 1st of 2018, is that supporting documentation for those different areas are included in the cost report, or your cost report is subject to be rejected when you've submitted it. So with that, we'll talk a little bit about uncompensated care. And again, within that uncompensated care area, the areas we're going to talk about is DISH, S-10, and the uncompensated care payment, and then Medicare bad debts. So a little bit about Medicaid, DISH Medicaid eligibility. So we obviously know that there were significant changes to the Medicare DISH adjustment with the Affordable Care Act that came into play. And beginning in 2014, traditional DISH payments were reduced by 75% to 25%. So your hospitals that are DISH, got only 25% of their traditional DISH, and then the rest of it would be paid through the uncompensated care payment based on your uncompensated care. So, it still is a very, 25% DISH payment, still very heavy. You still want to make sure you're doing everything to identify your Medicaid days, make sure all your policies are in place to identify the insurance that patient has, and if you get them, make sure you get them eligible for Medicaid if they're not. So still a lot of work that needs to be done around Medicaid to make sure you get that 25% of the bucket. So, DISH is one of those things that came into play many, many years ago. It started back in 1982 as far as being discussed, and through a series of different acts since 1982, 1984 and then 1985 kind of put this into place, and DISH payments started in 1986. And basically DISH was to reimburse hospitals for serving a high percentage of a vulnerable population. So Medicaid beneficiaries, low-income Medicare beneficiaries, uninsured and underinsured. So the hospitals that were serving this population received a additional reimbursement to serve this population. So this was a big payment that hospitals that fell into this category received. And how did hospitals qualify for DISH? What makes them eligible for DISH? So, DISH has two different components to it. It has the Medicare fraction and it has the Medicaid fraction. The Medicare fraction is basically the SSI percentage. So that's that days of patients entitled to both Medicare Part A and SSI total day. Oh, I'm sorry, is the Medicare Part A divided by total days of patients entitled to Medicare A. So that's how they got that SSI percentage. And that SSI percentage, as we all know, it's updated each year, and then it's distributed by CMS. So there's not a whole lot of work that you can do on that part of the fraction, but on the Medicaid side of it, the Medicaid percentage, that's that days of patients eligible for Title 19 Medicaid, but not entitled to Medicare. So really incumbent to make sure you are identifying all of your Medicaid eligible days, whether paid or not paid. There's different buckets that falls into, whether it's out of state or in state. But the big thing here is this is where DISH providers can really enhance their DISH payment, is by identifying all of their Medicaid days that should be allowed. Granted, it's right now 25% is what you get for reimbursement, but that's still a fairly good chunk, and that percentage impacts your 340B, which we'll talk about here shortly. So those two fractions put together need to be at least 15% for a hospital to qualify for DISH. So if you're between 15% and 20%, there are certain factors that are included in your DISH calculation. And then if you're over 20.2%, you're a super DISH hospital, there'll be higher reimbursement factors that are used. So really important to make sure that you identify all those Medicaid days to make sure you, number one, qualify for DISH, and then number two, are getting the right adjustment formulas that you're being put into. So where that really comes into effect outside of the 25% DISH is, 340B payments are tied to the DISH allowable percentage. So, there's a lot of things going on with 340B right now, and basically what is 340B? How did this come about? What is it? So, the 340B drug pricing program, basically, it's a discounted drug program for hospitals that, again, serve that vulnerable population. So they get these drugs at a discounted price, and then are reimbursed at a higher rate by HSS. So that additional funding is really used to be able to serve and stretch some scarce resources to a population of vulnerable patients. So that is where these payments kind of came into play. But over the last couple of years, there's been a lot of things going on with 340B. So as I mentioned, those additional funds are meant to really be reinvested in services for this disadvantaged population. But there's belief out there that the opponents of the 340B program, there's concerns about whether hospitals are really passing those savings on to patients. So based on that, some studies have been done, and payment reductions had been recommended and put into place for 340B. So basically, as of January 1st, 2018, 340B payments were reduced. So 340B hospitals were getting ASAP plus 6% before January 1st of 2018. After January 1st of 2018, payments were cut by roughly 30%. Basically, it's ASP minus 22.5%. So you weren't getting that additional 22.5% in your payments. So this reduction in payments to 340B hospitals were basically redistributed to hospitals that were not included in 340B programs to kind of in the way this program is being looked at, to reimburse hospitals, all hospitals, whether they were in the 340B program or not. So these cuts were basically estimated to be about $1.6 billion. So that was in effect for the majority or all of January 1st, 2018. But as you can imagine, there were lawsuits that were brought regarding these payments. AHA and other associations bought these lawsuits, and on December 28th, 2018, Washington federal fiscal judge had made a determination that CMS had overstepped its authority in making these 340B cuts. So there has been a permanent injunction put on this reimbursement policy. So in effect, it has reversed this policy. So what they're saying is hospitals should be being paid at the ASP plus the 6%. So you can imagine that, the hospitals that AHA represent were pretty happy about that win. For-profit hospitals, which this would obviously affect, we're not as pleased with that. So there you can expect there'll probably be some appeals around this issue. But as of right now, that reduction in payment, there's a permanent injunction on that. And there's supposed to be remedies that are being developed right now as to how do you make the hospitals that were affected by this, the 340B hospitals, how do you make them whole since they had experienced these reductions without hurting hospitals that have been paid these monies. Can't really go back and take that money away from the hospitals. So what are the remedies to make sure that the hospitals that the 340B hospitals that were affected by this would be made in whole? So that's yet to be seen, and that's what's being determined right now. And then of course, as I mentioned, the other thing is they'll most likely will be further lawsuits regarding that injunction on these payments. So that's kind of a stay tuned type of issue. The other things that are happening around the 340B is some additional reductions to the clinics that were grandfathered in that were not subject to these reductions in the past. So in 2019, the outpatient final rule came into play, and it implemented some more site-neutral payment policies. So one of the things that happened was in 2019, that reduction in that payment that I just talked about, that ASP minus the 22.5%, which right now had been extended to those exempted off-campus providers. So that was one of the things that got extended to them, but again, there's a permanent injunction on that right now. And then there's also another issue that's affecting these clinics to where they are going to be receiving a reduction in their payments for HIPIC code 463, G0463, which is the assessment and management code, which is a large portion of these outpatient clinics. So they're going to be reduced in their payments over a 2-year period. So basically, there'll be a 50% reduction in 2018 or 2019, and then the rest of that will be taken off in 2020. So that's kind of a phased-in effect for that reduction in that payment for that particular code. A couple other things around, or really one other thing around the 340B is there's legislation and talk about raising the DSH percentage. So if we go to this slide here, right now a hospital has to have a DSH allowable percentage of 11.75%. So a regular DSH hospital has to have at least 11.75%. Children's Hospital, freestanding cancer hospital, they all have to have at least 11.75% allowable DSH percentage. Now that is different than what we talked about before when we said that a hospital has to be at least 15% to be eligible for DSH. So once it goes through that formula that I was talking about, an allowable DSH percentage is arrived at, and that percentage has to be over 11.75% for those three categories of hospitals to be eligible for 340B. Well, some of the talk is that that they're looking at raising that to 18%. So instead of 11.75%, these hospitals would have to have 18%. It's estimated that that would eliminate a very large portion, over half of the hospitals that now receive 340B would be not eligible anymore for 340B if that were to happen. So that's just one of those areas that's out there that 340B hospitals have to be, keeping their eye on as to where that goes from here. In some of my discussions with people that are much more familiar with 340B and are dealing with it quite constantly, they don't expect that to happen, meaning it goes all the way up to 18%. They do foresee probably an increase in that 11.75%. Maybe midway between that, 13 to 14, 15% possibly it could happen. But it's from what I've heard, that going all the way up to 18% is probably not likely at this moment. Again, that's something that needs to be monitored for 340B compliance. Oh, I'm sorry about that. I was going the wrong way. Hitting the wrong number. Hitting the wrong key.
There we go.
So there we go. Now we're on. So basically, for DISH right now, for the uncompensated care, there's three factors in this. Factor one is the 75% reduction. So that traditional DISH minus 25%. That gives us this uncompensated care pool, and then that other 25% is what's paid through the traditional DISH. Well, factor two is basically the uninsured percentage. So through the Affordable Care Act, that uninsured percentage was supposed to go down. It was at 18% when this went into effect, and as we can see in this table, our uninsured had went down over the years, 17% down to 8.15% in 2018. You do see there's a slight uptick in 2019, which increased that dollar amount that's in this pool. So if you look at 2019, our traditional DISH estimate, so the amount that hospitals would have been paid under traditional DISH, was $16.2 billion. Factor one, 75% of that is $12.2 billion. So that's that original pool that we have for the uncompensated care payment. Then based on our factor two percentage, which is the uninsured percentage factor, that amount is taken down to our dollar amount of $8.2 billion that is redistributed back to hospitals through the uncompensated care payment. So you can see for 2014 through 18, that number had went down, and now we see a slight uptick in that because the uninsured population has moved up. So it'd be something that we'll see going forward, how that's affected. Factor three is the big change here. Factor three in the past, when it first came out, we were going to be using the information on S-10. In 2014, when this payment came into play, we were no longer going to be using S-10 information until CMS could rely on that information. They had been using a different way to come up with that number, similar to the way they came up with the SSI percentage. So that was a number that was, again, sent to us through the final rule each year. We would know what our percentage is for factor three. Well, in 2017, they came out and they said in the preliminary rule that they were going to start using S-10 information. Well, the final rule of S-10, the final rule of 2017 came out, and they had walked back on that. They said they still were not completely confident in those numbers. They're going to be doing some more work, refreshing the instructions and bettering the instructions around S-10 and what you report there. So for 2017, they were going to stick with the way they'd been using to come up with factor 3. Well, 2018 preliminary rule came out, and that was back in the preliminary rule that they were going to start using S-10 information. So between 2017 and 2018, they had made the decision based on what they were looking at that going forward, we're now going to use the information on S-10, and we were going to phase it in. And the components of the uncompensated care were going to consist of the charity care on line 23 and the cost of non-Medicare and non-reimbursable Medicare bad debt on line 29. So it eliminated some of the other areas that are on S-10 that came into the uncompensated care and is taking into consideration the charity care and the Medicare and non-reimbursable Medicare bad debt. So those two components is what's being used to come up with the percentage of factor 3. And that started in 2018. And that's phased in. So basically 1/3 of the calculation in 2018 was utilized. And then in 2019, basically 2/3 of S-10 information on S-10 is utilized, and then in 2020 the calculation will be completely reliant on what's on line 23 and line 29 for those two components of it. So just a quick tie back to the revenue cycle. Some of those key drivers, DRG payments, Medicaid eligible days, and SSI. So really what we're looking at here is when you tie that back to the revenue cycle, what's being done at the front end of the revenue cycle to make sure we've identified all of our Medicaid days, our medications, and what's being done on the back end of the revenue cycle to make sure that we're billing Medicare properly, to make sure that our dish payments are as high as they should be. Because if we're not billing properly, if we're not working denials, whatever the case is that's making us leave information on the table, our DRG payments on the cost report will be lower, thus lowering that amount for dish. Then, we talked about, we just kind of hit on some of these components of S-10 when we were talking about the dish, because they're very obviously intermingled. Basically, as I've said, 75% of what the traditional dish formula was is now that uncompensated care. And that 75% pool is going to be redistributed back to the hospitals. And then, here's that phase-in period that I was talking about for using that S-10. So 2018, we used that 2 years of proxy data, so that's that old information, and then 1 year of S-10, and then it's phased in over the next two years there. And then uncompensated care, the components that we're looking at are the line 23 and line 29. So a lot of things going on around the audits for S-10. Obviously, they're auditing that information. They audited that information over the past few months to determine where there were areas of things that needed to be corrected there. And basically, in the 2018 final rule, it basically said instructions from MACs are still under development and will be provided to the MAC as soon as possible. And then as we move into went too far. As we move into the audits, so proposed rule updates or the finalized rule updates for 2019, CMS has been instructed MACs to review hospitals with, high ratio of uncompensated care, and to look at different things that were a little bit out of the norm. So the final highlight from that 2000 rule is CMS is going to refine these instructions more for S-10. So data submitted by hospitals based on what has been learned from the review process will be in the 2019 and going forward rule. So it's really a basic of what have they learned and through these audits and what they will do going forward. So if we look at this last one here, the provider must submit a detailed listing of charity care and uninsured discounts. So we talked about that earlier, about that having to be finalized. So the past several months, obviously starting back in October, in September, hospitals got these notifications of the audits, and then in in October through the end of the year, hospitals are being audited. Well, those hospitals that were picked for these audits know that they were pretty detailed audits. They asked for a lot of different documentation that may or may not have been contemplated. So you could tell if you went through those audits that a lot of scrutiny is being put on the information on S-10, and in the 2020 rulemaking, we will see some further refinements as to what needs to go into S-10 to make it survive audits, to make it effective for this reimbursement process. So just a couple definitions here. As I mentioned, the things that are on charity care or in our uncompensated care is charity care and non-reimbursable Medicare bad debt. So uncompensated care is charity care and bad debt, which includes non-Medicare bad debt and reimbursable Medicare bad debt. The uncompensated care does not include courtesy allowance or discounts given to patients. And a really big thing here to remember on the charity care is the hospital has to demonstrate that the patient is unable to pay. So they've got to go through all their different policies and procedures to make sure they've identified that the patient is eligible for their charity care. The non-Medicare bad debt are the non-Medicare patients and unwilling to settle the claims, and these amounts would be subject to the cost of charge ratio on S-10. Medicare bad debt, so obviously when you have a Medicare patient, that Medicare beneficiary is responsible for paying their deductible and coinsurance, but is unable to pay that Medicare deductible and coinsurance. So this amount, obviously, we are reimbursed through the Medicare cost report through a different mechanism. We're paid 65% of that amount on the Medicare cost report, so it is not something that is included in this uncompensated care payment calculation. Obviously, CMS doesn't want to pay you for that 65% and then another amount in the uncompensated care. The non-reimbursable Medicare bad debt is that's the amount of allowable Medicare coinsurance and deductible that are considered to be uncollectible, but are not reimbursed. So professional fee type of things, screen fee type of things would not be included in your normal Medicare bad debt. So it's part of the uncompensated care payment. And then a couple changes to how we were looking at charity care. Charity care post October 1st, 2016, we were looking at services for care delivered during this cost report period. So it was charges that were written off for care delivered during the cost report period. So that's one of the things that changed going forward for after 2016. So basically, it was written off during this cost report period, regardless of when the services were provided. So that was two of the nuances that changed within that Medicare S-10 regulations on how charity care should be reported. So how do you work with your revenue cycle in collaboration to make sure that you're getting your uncompensated care? charity care reporting and bad debt reporting are some key drivers there. So what are we doing with bad debt write-off and comparing to our collection policy? It's all about the policies here. What are our policies in play? What's our financial assistant policies that are in play here? And are we following those policies? That's one of the things that we found in the S-10 audits, is that the policies were looked at, and were you following those policies? So making sure that throughout the revenue cycle, how these are being identified and recorded are based on the policies that are out there. Are we using the right transaction codes that are set up for these charity care? And when we pull that information into our log, are we pulling the right transaction codes? So by working with the revenue cycle department and them understanding the different nuances of how that affects it going forward, that can enhance your uncompensated care payment. Medicare bad debts is another portion of our uncompensated care that is a very big component of it. So Medicare bad debts are your Medicare beneficiaries, unpaid deductible, and co-insurance. Again, those things, some of the things around that must be related to cover services. Reasonable collection efforts are made, debts uncollectible when claimed as worthless, and you're using a good business judgment has been established to recover for recovery of bad debt. So all of those kind of things play into what you can claim as Medicare bad debts, and we'll talk about those in the next couple of slides here. But basically, 65% of that amount is reimbursed right now. That's that percentage is one of those areas that is always looked at as far as what is reimbursed for Medicare bad debts. It went through a series of ups and downs throughout the last several years. Had settled on 70% for a number of years, and then back in 2013 it was reduced to 65%. So that's where we stand right now, but that's always being looked at to, do we eliminate that? CMS looks at, should we eliminate Medicare bad debt reimbursement altogether? Heard that number going as low as 25% at times. It's always looked at during the budget process. But right now we're at 65%, so it's incumbent on hospitals to do everything they can to make sure that they have identified all of their Medicare bad debt, so they're getting that 65% of that amount right now. So amounts that would not be included in your Medicare bad debt. Amounts related to fee reimbursed services. Amounts related to professional services, those are not allowable Medicare bad debts. Amounts still at collection agencies, that would not be included. It's still being worked, it's not worthless, so that would not be included. Accounts that payments have been made on starting the 120 days over. So, if you've got this account out there that has been out there for, 119 days, and on that day the patient walks in and pays $1 of his coinsurance and deductible, that would start that 120-day period over again. And then Medicare HMO bad debt, those coinsurance and deductibles. So those are some of those areas that would not be included as coinsurance and deductible amounts being claimed as Medicare bad debts. So there's basically three buckets we need to look at it here for Medicare bad debt. There's a traditional bad debt. So that's your normal Medicare beneficiary that's not eligible for Medicaid. There's your Medicaid crossovers, and there's your Medicare charity care. So with the traditional, that's where a lot of the work is put into to make sure you identify that number. There's a lot of stuff that has to go into that area to make sure that you've covered everything, to make sure it survives an audit and hits on all the 7 highly effective habits of a Medicare bad debt. So the highlights around these are, it's a Medicare beneficiary, they're not eligible for Medicaid. that collection, that account has been returned from the collection agency. It is written off 120 days from the first bill. So basically, if you've done all your work up front, you've turned it over to the collection agency. The collection agency has done all the work on that to the where it looks like there's nothing else that can be done. It's bad debt. It's returned back to the hospital. That time frame is greater than 120 days. You can claim that on your Medicare bad debt for the current year. Some of the things that go along in that reasonable collection effort, the collection efforts, first of all, must be similar for everyone. So if you are turning all of your bad debts over to a collection agency, when you pull bad debts back, you can't just pull Medicare bad debts back. You have to pull all of the bad debts back. And they have to be pulled back in similar fashion. So if you've got a certain amount of time that it sits at the collection agency, and the collection agency works these accounts, you can't say, work the Medicare for 90 days and return those, and then work the non-Medicare ones for 120 days and then return those. It's got to be similar collection efforts, or it would not pass that reasonable collection effort scrutiny that it's put under. One of the other things that's being looked at quite heavily by MACs are the timely billing issue. So they want to know if you billed the beneficiary in a timely fashion to make sure that they had, that the bill was billed, the amount of time, reasonable amount of time went by, and the collection efforts were done to make sure that they weren't able to pay it. So that timely fashion really differs between different MACs. There's not really one set criteria, so it's kind of a moving target depending on what MAC you're looking at. Some of the things we've seen MACs use for that timely fashion, I've got kind of bullet pointed here. We've seen it where they looked at, did the MAC bill before 30 days after discharge? If they did not, they fell under that not timely billing, and it was in error. Bill beneficiary within 180 days of discharge. Amounts not billed within 180 days could constitute a non-allowable bad debt if there's not reasonable explanation for why it wasn't done. So it's another area that just recently has been starting to be being scrutinized and counted as an error in your calculation. One of the reasons with Medicare bad debts that you really want to make sure you do a lot of work on to make sure you get the proper amounts reported as Medicare bad debts is because, unfortunately, if an account is determined to be in error, if that account had, say, $1,000 co-insurance and deductible, it's not just that $1,000 that will be pulled off and counted as not a Medicare bad debt. It will be thousands of dollars more than that. So basically, a sampling error is determined based on their the MAC's sample procedures, and for each error they find, they'll come up with, say, it's $16,500 per error. So they'll pull that sample of 60 patients. They'll go through and they'll do their audit, and they'll come back and we found 5 errors, and each one of those errors are going to cost you $16,500 because they're extrapolating that to the whole population. So it's vitally important that these areas of concern are taken a look at and make sure that the numbers that are being reported are proper numbers. The next area here of importance are Medicare and Medicaid crossovers. So these are the dual eligibles. Basically here, really all you have to do is bill Medicaid in your state. Whether you know that they pay nothing or not, you do have to bill Medicaid and get, an RA that identifies it was billed and that nothing was paid on it, or that maybe something was paid on it and you've taken that out of the Medicare bad debt. But really the big thing here is you do have to bill in order to be able to claim the Medicaid crossover. The next bucket is the charity care. So again, these are the Medicare patients, traditional Medicare beneficiaries that were deemed indigent and meets the charity care policies. So on these, there's no collection efforts necessary. The indigence must be determined based on the charity care policy and take into account all of the patient's resources and if there's anyone else responsible for the patient's liability. And if you've gone through all that and identified that this could be a Medicare charity care patient, and you'd want to make sure you pulled that out of your number that you reported on S-10 for charity care. Again, you don't want to double count those in those two areas. So if you're getting reimbursed over here through the Medicare bad debts, you don't want to have that in your number you're reporting on S-10. If you get recoveries, again, that must be netted against your bad debt expense in your current year. If you do get recoveries, it starts your 120-day period over. So you need to make sure you're paying attention to your recoveries. Some areas around bad debts is make sure you are sending in separate listings for your bad debts, meaning you have a separate listing between Part A and Part B, separate listing breaking out your traditional from your crossovers. That way, the MAC will need to sample each one of those populations, and it should be extrapolated. Any errors that are found should be extrapolated only to that population. So if you find an error in the traditional bad debts, it's only extrapolated to the traditional population and not the crossovers. So that's one of the things you do want to make sure you're doing. This is one of those takeaways I talked about, just something for you to take a look at as far as, first of all, we got the required fields. Those are required in the bad debt listing for the bad debt listing to be good. And then on the other side is just kind of suggested additional fields for you to maybe take a look at your bad debt listing and see if there are anything there that you don't include in there. It's a really good thing to put in there and make sure that will assist your hospital during an audit if this information is in there. One area to look at, I mentioned that Medicare managed care bad debt, the deductible and co-insurance, that's not included in your normal Medicare reimbursement. But it is possible for you to maybe get reimbursement from your Medicare managed care company. It depends on the contract. So if it's in the contract, you possibly could get your Medicare managed care portion of this reimbursed from the Medicare managed care company, not from Medicare itself. So you don't want to have it in that number. But if you have a significant amount of Medicare managed care, it might be something you want to take a look at to see how your contract states how those will be handled, and possibly you could get 65% reimbursement from your Medicare managed care company. So just a thought bubble out there for you to think about. This next one is kind of a bad debt interim asset process. So really, you should be looking at your bad debts, halfway through the year and kind of walk them through these steps and make sure that they pass all of these different areas. That way, you know that whatever's going on in your bad debt process is working, and it will survive the 7 highly effective habits of a Medicare bad debt and will survive an audit of it. This is kind of another takeaway from you to kind of take a look at your bad debts on an interim basis to make sure nothing's changed or nothing's went wrong in the process and everything on your bad debt process is working right. Again, the key driver here is really that auditable documentation. So just making sure, number one, the policies are in place, transaction codes being used are right, Medicaid billings are being done, and anything going on in the revenue cycle around these areas are attuned to this and what you need for Medicare bad debts. So with that, I'll open up to questions, hopefully we've kind of met your objectives here as to what you hope to get from it and take a little bit away from it. But if there are any questions, I'll be happy to entertain those over the next few minutes.
Great. Thank you so much for that, Chad. So as he mentioned, we do have a few minutes for questions. Just a quick reminder, if you have any, feel free to type those into the questions chat panel, and we will address as many as time will allow. Our first question actually has to do with the slides. So yeah, if you missed the initial introduction, don't have to wait for those. Just scroll down to the right-hand floating panel to the side of your screen and expand the handouts panel and click on that PDF icon. You can get access to them right now. All right, Chad, of the three categories of Medicare bad debts, which one would you say has the most audit issues?
Good question. Yep. So that the one that has the most audit issues are those traditional Medicares. So the Medicare beneficiaries. That's where most of the regulations are surround around the reasonable collection efforts. So the Medicare crossovers, there's no collection that has to be done. You just have to bill Medicaid. The Medicare charity, you do have to go through the charity care policies. And auditors do review those. They'll check a portion, sample of that, and take a look at whether that policies were followed and if the policies were sufficient to cover everything that it needs to be covered. But really, the traditional Medicare is really where with the collection agencies and what's going on in the collection time before it goes to collection agencies, what's happening at the collection agency, and is everything past 120 days. So that traditional Medicare bucket is really one where you want to pay a lot of attention to.
Thank you for that, Chad. And if I may, I believe, do you have a contact slide? You may want to advance to that one because I think we may have time for one more.
Yep.
That way, if you guys think of other questions, Chad is nice enough to extend his contact information so that you can reach out to him directly. All right, so our next question is, how is the Medicare cost report utilized in strategic decisions around uncompensated care payments?
Yeah, good question. So the big thing that the Medicare cost report is utilized is to take a look at, say we're looking at bad debts. We're taking a look at, okay, our Medicare bad debts were this much. How much are other providers in our state getting for Medicare bad debt? And you can find that information through publicly available information out there. A lot of hospitals will subscribe to different agencies that you can get a Medicare cost report from or get different benchmarking data from. And one of those big things they look at is that Medicare cost report and the bad debts that are being reported on those Medicare bad debts. So just the Medicare bad debt alone, you can take a look at what your hospital in your state's doing compared to what other hospitals within your state are doing. And are you falling, maybe way below what other hospitals are doing? And if so, why is that? What can we do to enhance our areas, those reimbursement revenue cycle drivers? What can we do in all of the areas, DISH, S-10, and Medicare bad debts? What can we do to enhance what we're doing so that we don't look, I'll say, out of whack or not doing the same type of things maybe another hospital's doing within our same geography that we should be doing. So just in those three areas, that benchmarking is really where the Medicare cost report comes into play.
Great, thank you for that. Okay, so as we approach the top of the hour, I just want to take time to thank our members in the healthcare community for joining the call. Later this month, HFMA will be hosting a workshop on cost reporting as a strategic decision tool. This will actually be in Walsenburg, Colorado. Space is limited, so be sure to visit hfma-co.org for more information. Thank you again, Chad, to our guest presenter, Chad Krcil of CROWE. We really appreciate every time you're able to join us and share your expertise. So we're really grateful that you took time out of your schedule to prepare and deliver. And
yes, absolutely. Yep. And I'll just put a plug in for that workshop. That's a 3-hour workshop that I'll be conducting. We'll be talking a lot more in depth on some of the other topics around the Medicare cost report and how to use that as a strategic tool for reimbursement. So if you're in that area, or there'll be 2 other workshops given in other rural areas too that are on our website. Please take a look at those, and if you can join, we'd love to see you.
Perfect. Great way to end it. Have a great afternoon, everyone.
Thank you.